Welcome. I'm Keith Stewart. I'm a hematologist at Mayo Clinic, and we've just finished the first day of our Myeloma 2015 meeting in Boston. I'm joined today by two of my esteemed colleagues, Professor Jesús San Miguel from the University of Navarro in Spain, and Professor Antonio Palumbo from the University of Turin in Italy. We're going to discuss three of the sessions that were conducted this afternoon. And in the first of those, we examined the increasing evidence that perhaps we should treat myeloma at an earlier stage of its development, a condition we call smoldering myeloma. And Jesús, you presented some very provocative data from Spain and talked about your planned clinical trial. Would you like to tell us a little bit about that?
Okay, I think the first comment that I should make is about what we understand by a smoldering myeloma. It's an intermediate stage between the MGUS, the benign profile, and the active multiple myeloma. What we have shown, together with the Mayo Clinic and other groups, is that within this group of patients, there are standard and high risk and ultra high risk patients. And are the high risk patients, they are ones that are the target for treatment. We previously shown that continuous treatment with lenalidomide and dexamethasone was associated with a significant delay in the time to progression and overall survival. And now we are trying to prove that this cohort of patients can be curable by using more aggressive treatment, including transplantation, in the setting of patients less than 75 years of age.
And this is somewhat inspired by Dr. Langen's work from New York, in which he showed that the combination of carfilzomib, lenalidomide, and dexamethasone produced 100% complete response in these early myeloma patients, thus raising the possibility of cure. Is that correct?
That's correct. And we are going to use KRD as induction, transplant, then KRD consolidation, and then maintenance. And in this setting of patients, we are going to analyze the minimal residual disease after each step of the treatment.
Dr. Palumbo, how do you react to all of this?
Well, I think there's a major concept that is coming. And in the early phases, the disease is much more sensitive than later on. We have been already seeing in myeloma, stage 1 myeloma is doing much better than stage 3. And so more and more evidence are coming that early intervention might be more beneficial because in the clonal evolution of the disease is probably more sensitive. More you wait, more you have additional genetic mutation, and more the disease might become more resistant. So I think that's an important concept, and probably in the future we will have to change the criteria to define when we should start treatment.
Very excited to think that we might cure patients by treating them early. Our second set.
But let me say, it's not different from other cancer. If you think in prostate cancer, in breast cancer, in lung cancer, early intervention is always associated with better outcome.
Of course, but they have treatments which are surgical and non-toxic. We have to rely on chemotherapies which do have some toxicities, and we saw that today in the presentations. There was, a case with some renal dysfunction and one with some cardiac problems. So let's talk a bit about high-risk myeloma, because that was the second session today. And what did you take away from that session, discussing how we treat the more aggressive myeloma patients?
Well, certainly I would say that today we shouldn't divide so much high risk from standard risk. High risk has a poor prognosis, but probably the treatment should be equally intensive in the standard risk, because if you give an intense treatment, the standard risk will do exceptionally well and the high risk will do slightly less. But I think the other concept that is coming is that with more effective treatment, with more therapy that are more specific for myeloma, we can probably transform a part of the high risk in a standard risk disease. We have seen it already with bortezomib and the 414 translocation. The use of a more intense treatment is basically overcoming the high risk coming from the 414 translocation. Certainly this is not yet true for deletion 17, but probably again in the future with the new monoclonals, more effective treatment, I think we could probably rescue also some of those high-risk populations. So certainly for them today, combinational therapy is a must. Continuous therapy is a must, but probably in the future we might even significantly improve the outcome of those patients.
You agree, Dr. San Miguel?
Yeah, I agree, but at the same time, I think we need to learn more about this high-risk population because probably they may have some genetic lesions that we need to identify those ones that may benefit from targeted therapy. And now we are in the facing the possibility of having targeted therapy just druggable for those genetic lesions. And then I think similar again to what is being happening with a solid tumor, probably in multiple myeloma, we need to dissect between the high-risk specific genetic lesion that may benefit from different approaches.
We heard earlier today about the progenitor cell of myeloma and how it might be a little bit different than the plasma cell, and we talked about maybe using the anti-CD38 monoclonal antibodies. Yeah. Do you think that will be enough to overcome high risk and remove that other clone, or we need another set of drugs, which we'll talk about in a second?
There is the hope. We do not have data today to clearly say this might be an option for the future. There is the opportunity. We have to see it, basically.
I think anti-CD38 has shown already high efficacy in multiple myeloma, but at the same time we have experience in patients with very high risk genetic lesions that they have not responded, or if they have responded, that they had relapse very early on. Then I think we need to improve yet.
And Dr. Orlowski talked about a clinical trial that's starting in the United States where the drug elotuzumab will be combined with some of our best chemotherapy agents in the high-risk population to see if that will help high risk, but these are clinical trials at this point. The last session today was on new drugs. It's always the most exciting, the drugs that haven't really been explored too heavily in the clinic yet. Which of those caught your attention today, if any?
I think inhibitors of exportin are really attractive drug because they can probably help the cell to maintain suppressor genes that may control the disease. And in combination with corticosteroid, they have some high activity in the setting of relapse.
You're talking about selinexor,
Selinexor.
right, from Karyopharm Pharmaceuticals. Yeah.
Then I think this is one of the drugs that attracted my attention.
Yeah, very impressive results.
Yeah,
what did you think of
I would agree
those?
that both selinexor and rosilinostat, that is the other HDAC inhibitors with a very good safety profile. I think they are the most interesting new compounds coming, probably a help to overcome resistant disease. So I think that's certainly two compounds that will have a future in myeloma.
And the latter one, this is a very specific HDAC inhibitor from acetylon, yes?
But more importantly, I think, in my opinion at least, is the safety profile. Can be delivered very nicely. You cannot, you know, the discontinuation is low, and probably this might represent a major plus for the treatment.
And we heard a little bit of ibrutinib just to close. This is a drug for Waldenstrom's macroglobulinemia, a related plasma cell dyscrasia. And very important results published in the New England Journal of Medicine this week, which I didn't know until today, actually. Yeah. But what did you think of that? And do you think there's a role for ibrutinib?
It's been published today, basically.
Yeah, I guess. What do you think about the role for that in myeloma?
This was fascinating, the data and also the mechanism of action. And this is what I said. Probably if we think about targeted therapy in the high-risk myeloma, because this was the case, the BTK inhibitor in a case that they have the MYD88 mutation and is activating all this pathway, then there is a clear rationale. In multiple myeloma, I am not sure if it is going to work in the same way, but interestingly enough, we have seen today that this drug mainly acts in the plasma cell compartment, not in the B cell that is what I was expecting.
Right.
Then I think this is intriguing and probably is worth just to try in multiple myeloma.
Any closing thoughts, gentlemen, before we finish? Anything else that caught your attention that we haven't discussed just now?
Well, I have just one comment because I think ibrutinib has not been tested in myeloma, but to some extent represent as other drugs that may act on more immature compartment of the myeloma tumor and might be something to test in the future. But certainly, for me, the close comment is that I've never been such a great time for myeloma, so many new compounds, so many opportunities. I think there is a sort of biotechnology revolution, at least for what concerns our disease, and I think things might change dramatically in the near future.
That sounds like a good place to close, and we'll be back tomorrow to tell you about the results of our second day of the conference. So thank you for joining us.